Okay, hopefully you can all see the first slide now and can at least hear me. Is
That's
that
great.
good?
Yeah.
Good. Okay, so as we were saying, what we're talking about today is fuel poverty at the end of life, and I'm going to discuss some new research we've been doing on social tariffs. So to give you a bit of background, the structure of the presentation is going to go like this. There'll be some background on the existing research and some headline statistics on some work we did last year for Marie Curie, looking at who's at risk of fuel poverty. And then I'll be sharing a bit of new research where I've looked at the role of social tariffs, about who's lifted out of fuel poverty and who's left behind. Then we'll run on to some conclusions and some policy recommendations, and that will lead directly into what Jamie would like to talk about with regards Marie Curie's policy asks on this. So to give you a bit of background, this is part of a larger programme of work that's been ongoing between the Centre for Research and Social Policy and Marie Curie, looking at dying in poverty. And we've been analysing different aspects of poverty, and this work in particular was about fuel poverty. So our previous research found that in dying in poverty in 2023, we had an estimated 128,000 people who were dying in fuel poverty. And the research examines the risk of fuel poverty in the last year of life, changes to energy spending in the last year of life, and we've also modelled the impact of a social tariff on reducing energy bills by 50%. And I'll tell you more about that later. So how do we measure fuel poverty at the end of life? Well, you'll all be familiar with the definitions of fuel poverty, where we look at if someone's spending more than 10% of their income on energy, then they're considered in fuel poverty. However, one drawback of that is that it can include high earners who are also high energy consumers. We could add a threshold to that so that we only include those people who are on very low incomes, and then target households who are specifically on below 60% of the median income. The measure that we use in England to measure fuel poverty since 2021 has been the low income, low energy efficiency measure. So in addition to being on a low income, it only includes those who are in homes where the energy performance certificate for the building is EPC-D or worse. So that would mean that if you were in an energy efficient house, then regardless of what you were spending on energy, you would be, regardless of your affordability, then you would still not be considered in fuel poverty if the house was in good condition. So this tends to target improving housing energy efficiency as a way of reducing energy need, to reduce energy bills, and as a route out of fuel poverty. However, one of the problems with that is it tends to be unresponsive to energy prices. So it's unhelpful in the context of the sort of rising energy prices we've seen in recent years, and it's not useful for assessing affordability. And also, if you're considering people at the end of life, improvements to housing are very disruptive and very invasive in everyday life, and they may not deliver results in a sufficiently timely manner to help these people who are in particular urgent need. Which brings us to the measure of fuel poverty used in Scotland, where if you're spending more than 10% of your income on energy and your resulting income after you've paid for your energy is below 90% of the minimum income standard, then you're classified as in fuel poverty. And one of the benefits of this is it assesses whether the net income you have remaining is enough to live with dignity. And it also varies by household composition, so it can adapt to the variation in needs for different family types. So this is the measure we selected as most appropriate for use at the end of life. To give you an overview of the headline statistics on this, fuel poverty is higher in the UK for people in the last year of life, regardless of which of these measures we use. And the chart here shows in purple people who are not in the last year of life, and in the pink people who are in the last year of life. And this is for the entire adult population aged 20 plus. And the vertical axis here is the risk of fuel poverty. So in all these cases, we're seeing the risk of fuel poverty rising in that last year of life. And we did find particular subgroups who were at higher risk than others. For instance, working age single households, because of the impact that being in the last year of life and being terminally ill can have on your ability to work. If you've no second income to fall back on, then that's more challenging. We found that minority ethnic groups tended to have higher rates of fuel poverty even before they were in the last year of life and were at a disadvantage. And the same applied to social housing tenants, because generally it's only the most vulnerable who are in social housing these days. And there's a disproportionate number of people with a disability in social housing. And we also noted regional differences, with particularly high rates of fuel poverty in London, Northern Ireland, and the northeast of England. So where do social tariffs come into all of this? Well, the role of social tariffs is to provide cheaper services for people who are vulnerable or who would be unable to afford those services otherwise. And the terminally ill experience a loss of income because of the impact on their ability to work if they're of working age. And there is also an increased energy need, which is due to many terminal conditions affect circulation, or mean you're less mobile than usual, and that can mean that you need to have a higher ambient temperature in the home. And it can also mean that if you're no longer working, you're spending a lot more hours at home, and therefore you need the heating on for more extended periods of time. And another factor that comes into it is if people need to run equipment to help with their illness, and that can add to their electricity bills and energy bills. And surprisingly, there is a lack of existing research on fuel poverty and terminal illness. So the new research we've been doing, based on the data we used in the Marie Curie report, was to establish which demographic groups benefit from reduced inequality in fuel poverty when a social tariff is applied to energy bills for those in the last year of life. And this is work that we've currently got submitted to a journal paper. So to give you an overview of the method, the data we've been using is from Understanding Society. The reason we chose that survey is because it covers approximately 40,000 households, so it's a large sample size. It's also a longitudinal study, so we're able to see how this is changing over time and how things are progressing. And having data from 2011 until 2023, we were able to use that entire period to smooth the impact of exceptional events, for instance, the COVID-19 pandemic. It also helped to maximise the sample size we were able to analyse, and we could use it to identify retrospectively who was in the last year of life. So if people in 2023 were flagged up as deceased, then 2022 was categorised as their last year of life. And this survey includes a range of variables that are useful for us here. It covers income, benefits, pensions, and earnings. It also covers energy spending and various demographic factors. So what we did was to derive a fuel poverty metric, which I described earlier, and we then applied an example 50% social tariff across the entire range of the energy bill. That covers unit rates and standing charges for all energy sources. We then looked at who was lifted out of fuel poverty and who was left behind. And we then went on to look at whether it was statistically significant. So we derived odds ratios and looked at the confidence intervals on that. So, which really brings us back in a way to the choice of metric. How we measure fuel poverty determines how the whole concept is framed and how we choose to address it. And there's been a prevailing narrative really of if we fix the house, then the problem is solved. And that's driven the fuel poverty strategy in England and internationally, which targets building energy efficiency as a route out of fuel poverty. However, as I've said before, and I'd really like to emphasise, that isn't appropriate at the end of life, and it does nothing to address income adequacy, which is why we chose the Scottish fuel poverty metric. And so we're looking at people who are spending more than 10% of their income on energy and who have a net income after paying their energy bill of below 90% of the minimum income standard. And MIS is based on what the public agree is necessary for an acceptable standard of living in the UK, a satisfactory standard of living. And it varies by household composition, and it adapts to the needs of different family types. So if we look at the underlying raw data to begin with and look at the risk of fuel poverty for different demographic groups, we have here couples on the left, and on the right we have single people, and on the vertical axis we have the risk of being in fuel poverty in that last year of life. So we see here that people in a couple have a 17% risk of fuel poverty, and those who are single have a 40% risk of fuel poverty. So what I'm trying to emphasize here is that some people start from a position of greater disadvantage. So if we look at who is lifted out of fuel poverty, if we look at before a social tariff is applied, on the left here we have couples, on the right we have single people, and this line in the middle here is the fuel poverty threshold. So in the purple we have people who are in fuel poverty, so they're spending more than 10% of their income on energy. In the pink, we have people who are in extreme fuel poverty, who are spending more than 20% of their income on energy. And what we find when we apply a social tariff and reduce the prices by 50%, these people in the purple jump up over that fuel poverty threshold, whereas the people who are in extreme fuel poverty are still in fuel poverty of some sort. So if we go on to look at what proportion of these different categories are lifted out of fuel poverty, we find 51% of couples are lifted out of fuel poverty by a social tariff, whereas only 40% of single people. So it's favouring even more the people who have the lower risk of fuel poverty. So what other categories did we look at, and who's lifted out of fuel poverty and who's left behind? Firstly, we looked at partnership status, and we found that a greater proportion of those are lifted out of fuel poverty for people who are in couples, and a greater proportion remain in fuel poverty for those who are single. In terms of whether the household receives any disability benefits, if you have anyone receiving disability benefits, then a greater proportion of those remain in fuel poverty, whereas a greater proportion of those who don't receive any disability benefits, don't need any disability benefits, are lifted out of fuel poverty. Similarly, when we look at housing tenure, a greater proportion of those who own their own homes, regardless of whether it's with a mortgage or owned outright, and are lifted out of fuel poverty, where a greater proportion of those in rented accommodation, whether that's private or social rent, remain in fuel poverty when a 50% social tariff is applied. And you'll notice that all of these groups on the right here, there are all subgroups that have a larger proportion of individuals below the minimum 90% of the minimum income standard. These are the groups with a higher risk of fuel poverty, where a greater proportion are remaining in fuel poverty. But we don't know at this point whether these differences are statistically significant. So what we went on to do was to look at odds ratios and to work out confidence intervals on that. And what we found was those who were likely to remain in fuel poverty with a social tariff are households where someone receives disability benefits, and those in rented accommodation, whether that's private or social rent. And both of those aspects are significant at the 99.9% level. When we looked at partnership status, whether someone was single or in a couple, that wasn't significant even at the 95% level. So there are a few limitations to conducting research this way. Firstly, it's secondary data analysis, so we're very much reliant on the information provided by the existing survey. If we have other interesting questions we want to ask, we can't do that. And we're also dependent on whatever response rates they get from that survey, which is why we're unable to look at some of the interesting things like whether people were on prepayment meters and whether they were able to keep comfortably warm in their own home, because people had opted not to answer some of those questions. Another aspect to consider is we're using energy expenditure data here to calculate a measure of fuel poverty. and that doesn't identify people who can't afford to heat their homes adequately. So there may be people there who are really managing their budget down, who are actually living in the cold and should be heating their homes a lot more. Also, a social tariff may not necessarily reduce fuel poverty. People might continue to spend up to their budget and simply enjoy a warmer, more comfortable home, which is, well, that's going to be a win for people who are in the last year of life. And a main limitation, as I mentioned earlier, is sample sizes. So that there weren't always the sample sizes, especially when you consider a mortality for people of working age. The sample sizes in that are quite small. So to conclude, applying a social tariff of half-price energy would be beneficial to all in the last year of life. And some vulnerable groups are lifted out of fuel poverty by a social tariff, but it's not enough to help those in extreme fuel poverty, those who are spending more than 20% of their income. It can't lift them out of hardship. And it tends to favour already advantaged groups, such as owner-occupiers and households without a disability, because they might be only just in fuel poverty, so it's quite easy to lift them out of it. So what are the policy implications of this? So certainly I think I've drawn attention to the nature of threshold definitions. You might only be £1 a month better off than your neighbour, and you could be out of fuel poverty and yet they are in fuel poverty. It doesn't mean you're fine, because you've nudged over that threshold of fuel poverty. So it might be more beneficial to have a taper rather than a cliff edge, have a sort of fuel poverty scoring system perhaps. And more targeted support is definitely needed for those who start with greater disadvantage. And that's particularly concerning at the moment for those who are dependent on disability benefits, and there are future concerns over the planned changes to welfare. And those in rented accommodation, again, we see in a context of ever increasing rents making that, pushing them into greater disadvantage. And existing fuel poverty interventions target the least energy efficient housing first. Perhaps we also need to focus on affordability and vulnerability, and target those who are struggling with the affordability issues and those who are the most vulnerable first. And who could be more vulnerable than those who are in the last year of life, and they are much more likely to be in fuel poverty at that point. And we could do something about this. We could have access to a social tariff added to the package of support available to those with a terminal diagnosis. So thank you very much for listening. This is just a small taste of work we're doing, and if you could look up the previous report and take a look, you could find out more. I'm more than happy to receive emails on this. And we are currently conducting an update to this work for Marie Curie, which hopefully will be published in November. So thank you very much.
Thank you. Really interesting. I'm getting a set up, so hopefully no one else is getting that. Thank you, really interesting. And sorry, the video didn't seem to work. I can see it's working now, so that's great.
Yes, and there were lots of things pinging in the background, but I managed to ignore that.
So we'll press on. What I should have said at the start, amongst probably other things, is that we are recording the session and we will be making the PowerPoint slides available. I know people like to know that in advance. So please, I can see some questions coming in. Please keep thinking of your questions. And now I'm going to hand over to Jamie. If you'd like to put your camera on and share your screen, Jamie, then we look forward to hearing from you.
Thank you, Graham. I think you might also need to turn my camera on.
Okay.
Thank you.
Right, I think that lets you turn your camera on now. Great.
There we go. Yeah, the big reveal. Right, and now I'll share my screen. I'm hoping that someone just confirm you can see that.
That's great. Thank you.
Thank you. Lovely. Well, hi everyone. Thank you very much for the invitation to speak to you today. Really pleased to be here and talking about this really important issue. My name's Jamie, and I'm the Senior Policy Manager for Financial Security at Marie Curie. Just by way of very quick background, I'm sure many of you know of Marie Curie, and there's still sometimes a misconception that we are still Marie Curie Cancer Care. Actually, these days we deal with any terminal illness, and we're here to advocate for and support anyone with a condition that you're likely to die from. There we go. So the research that Elaine has outlined and referred to came from the fact that financial security is a really important area for Marie Curie, as well as, of course, to people who are at the end of life and those around them. We see this in our own frontline work that I know Sarah's going to talk more about her perspective on later. We also know that, frankly, terminal illness can be expensive. Your costs rise, especially often energy, but that also happens at the same time, particularly for working age households, as your income drops. Somebody with a terminal diagnosis might need to reduce their hours or stop working altogether as a result of their condition, but so too might their partner if they're providing care for them. So that can have a double impact at a really difficult time. So in 2022, we commissioned Loughborough University and the Centre for Research and Social Policy to develop an analysis of deaths in poverty, and we published a report on that. This research, the latest research that was published in November last year, updates that, and for the first time, as a really important element, was able to include estimates of deaths in fuel poverty or fuel poverty in the last year of life as well. Sorry if you can hear a shutter opening behind me. So the headline figures from that research from last year was that altogether 111,000 people die in poverty every year, and that is notably higher among working age people than pension age people, as well as almost half of working age Black people who die in poverty. So these effects are not evenly distributed across the population and very much reflect existing inequalities as well. When it comes to fuel poverty, we found that at least 128,000 people die in fuel poverty every year, which is much more equal in terms of percentages between pension age people and working age people. The raw numbers of pension age people dying in fuel poverty are higher simply because more people over pension age die. And deaths in fuel poverty are more common in London, the northeast of England, and Northern Ireland. We also, this is from a separate piece of Marie Curie research, but if planned rises to the state pension age that have already been announced, more than 15,000 people a year will die before they can access the state pension. And that difference between the working age and pension age benefit system and social security support is, I think, a big driver of the higher proportion of deaths in poverty among working age people than pension age people. So when we're thinking about how to develop ways we can advocate to address this situation, obviously one part of dealing with fuel poverty is simply dealing with poverty. If you have more money in people's pockets, they are more able to afford the energy that they need. So some of our main recommendations in that space, I mean, a first big overarching one is to have a plan for government to recognise this as an issue, poverty at the end of life, that needs to be dealt with. We don't have anything like that at the moment. It's dealt with in sort of bits and pieces, mostly through the benefit system and not in a particularly effective way. We'd like to see the introduction of a guarantee for a state pension level of income for working age people living with terminal illness. At the moment, if you die at 64, you might have paid in to the state pension for a long time, but not be eligible to access the state pension and die before you can make any use of it, which means that you're left reliant on the working age benefit system, which, as I say, is much less generous. that could be done in a number of ways, and we're agnostic about how it's done. But one possible option would be to adjust universal credit, so maybe adjust the health element of universal credit, the amount that is paid to someone who qualifies under the special rules for terminal illness, or it could be done by opening up access to the state pension itself for people in that situation, which we're hoping, and we'll certainly be pushing for the recently announced Pensions Commission to be considering as well, because that's never been explicitly considered in previous reviews of the state pension. Another important element here, and this is possibly slightly outdated by now, but this financial year is intended to be the last year that people will receive old style benefits, so things like income-based employment support allowance and housing benefit for working age people as well. That process is rolling out, as far as we can tell, relatively smoothly, but there are big latent risks within it, and particularly for terminally ill people who might struggle to attend an appointment to verify their identity, or actually just return the form that they need to do in order to make that move to universal credit. So that's a concern for us as well. Specifically thinking about fuel poverty, Elaine mentioned that one key across the board issue here is the lack of any sort of consistent support with energy costs. We think that a social tariff is probably the best way to deal with that. There are absolutely, and I note that someone's already asked a question around that in the chat. There are absolutely really important design issues around that to work through and deal with. I also don't think in practice any social tariff would solely apply to people with a terminal illness. I think first of all we need to get an agreement to introduce any form of social tariff in energy, and then we can work out how that works in practice. It's been under discussion within the Department for Energy Security and Net Zero, but so far there's not been any announcement or any confirmation of that. So that's, I think, a really important across the board thing that we need to do. As Elaine also mentioned, though, even quite a substantial social tariff of 50% doesn't move all households out of fuel poverty. And one reason for that is the running costs of medical devices that can really stack up as well. Often the NHS will provide medical devices, but there are only certain types of devices that you get any sort of reimbursement for the running costs of, and those tend to come in arrears. So not only is there a real patchwork of provision depending on what device or devices you might need, so we could be talking about things like ventilators, a powered wheelchair, a bed that sort of undulates to help relieve pressure sores if you're in bed for much of the day, and so on. The cost of those can really stack up, and just the lack of support with the running costs for those is really prohibitive. And I think that's another key area over and above a social tariff that would really provide benefit to people at the end of life. Another issue in this area is around the winter fuel payment. Obviously, there was at one point plans to greatly restrict it to people only receiving pension credit. That's now been expanded back quite a long way, which I think is a good step. But even under the previous system, that this wasn't something available to people of working age at the end of life, and we'd like to see that expanded. I think a key thing to remember when you're thinking about people at the end of life in more generally is not only that, as Elaine mentioned, often things like energy efficiency measures, either they're not quick enough to actually deliver benefit while the person is dying, or they can be quite disruptive and so not really appropriate. But the other thing is that the nature of the additional costs that can come with a terminal illness often mean that actually financial difficulty can extend further up the income scale than you might think. So I think sort of hard cut-offs around, for example, pension credit for access to the winter fuel payment really miss miss that. And I think that's a really important part of thinking about the financial security of households in this situation. In terms of next steps, Marie Curie has a campaign around what we're calling the cost of dying crisis, and we're continuing to promote the petition, which we'll be handing in towards the end of this year to the Department for Work and Pensions and the Department for Energy Security and Net Zero. We're encouraging hospice services and palliative and end-of-life services to download or order our guide that we produced in partnership with Children North East around poverty-proofing palliative and end-of-life care services, particularly looking at ways that these services can help to make what they do more accessible and sort of suitable for people with on a low income, acknowledging the financial pressures that that sector is under as well. So trying to think sort of creatively, trying to problem solve around ways in which that can be improved. And as Elaine mentioned, we have updated figures on deaths in poverty and fuel poverty coming later this year. Elaine said hopefully November. I'm going to go out on a limb and say definitely November, because there's a whole machine at Marie Curie that is gearing up for that. So I need to make sure that I do hit those particular deadlines. I think that's everything from me, but I'm going to end because ultimately this isn't about me or Marie Curie specifically. It's about the people who are in these situations, and I'd just like to end with a quote from a lady called Gillian, who cared for her mother at the end of her life. She didn't like to admit to me that she didn't have money for food, but I went to do a shop for her one day, and she had to tell me that she didn't have the money to pay for it. I'd find her sitting in her pajamas, a housecoat, and a blanket, worrying about putting her heating on because of the cost. The last thing that anyone needs when they know that they're dying is to be worrying about financial issues. People shouldn't have to cope with that on top of everything else that they're already going through. And I don't think I could put it any better than that. Thank you very much.
Thank you, Jamie. That's the really powerful quote to end with there. Just a reminder of how this really affects people, these challenges. So thank you. Before we move on to the Q&A, I'd like to invite Sarah to give us share some reflections on what you've heard, and also, as you said, draw on your kind of previous experience. I think you can turn your mic on, but let me know if it doesn't let you. You're shaking your head. I guess that means no. 1 second. It should, here we go. How's that? Does that give you the option to unmute yourself?
Yes, it does. Thank you. Yeah,
sorry about that.
Do the cam, but not the volume.
Hey.
So yes, thank you, and hello everybody. So my name's Sarah Owens. I'm a senior lecturer in adult nursing at the University of Salford, and I've been a registered adult nurse for almost 28 years. And I've been very lucky and privileged to be able to spend the majority of my clinical experience working in palliative and end-of-life care, and work within a hospice environment, initially for many years as a clinician, and then latterly as the lead palliative care educator for the borough in which the hospice sat. So I'm extremely passionate about palliative and end-of-life care. And as Cicely Saunders says, who is the founder of the modern hospice movement, the way that somebody dies remains in the memory of those left behind. And within that role, within a hospice, or as a nurse providing end-of-life care, palliative and end-of-life care in any clinical environment, our ultimate goal is to ensure that people live the best of the life that they've got left, and that they have as good a death as possible. And I think it's important for us to think about how we define the end of life, basically. So within the key documents that have been produced around palliative and end of life care, end of life is discussed as the last year of life. And then, of course, we have people who are literally approaching the end of life, that we refer to those people as being those that are actively dying. And that's usually within, they've got probably 48, 72 hours of life left. But as we know, that's not an exact science. The prediction of that, people will die when people are ready to die. And it's sometimes kind of difficult to predict, and then as a consequence is planning on getting in services in place, really. So how do we define it? How do we understand it, not only as professional people, not just necessarily healthcare professionals, but how do the general public understand when they are told that they've got a life-limiting diagnosis? What do they understand about that? What do they understand around the word palliative? What does that mean? What does end of life mean? And a lot of terminology that's not often explained in a way that people understand, so people can feel a little bit confused from the offset, really. And, you know, in terms of documentation, the end of life care strategy right back in 2008 was a really significant document that galvanised the health and social care system with 3 key insights, really, which talked about people weren't dying where they wanted to, and we needed to prepare for a larger number of people. So as the population grows, as our technology advances, but also our the illnesses that people are diagnosed with kind of get cleverer, if that makes sense, and treatment needs to change in an attempt to manage symptoms and move as somebody becomes more poorly. And what was found then as well, that not everyone received high quality care. So I noticed when I was looking through Elaine's report, there was reference to dignity, and that's extremely important for anybody receiving healthcare, regardless of diagnosis, but especially for somebody who's approaching the end of their life. But we want people to be able to live as well as possible until they die, and dying well wherever you are, whatever your circumstances or background. And I think from listening to what's been said so far, I completely can see those multiple variances that have been within practice. So when we are discharging people from services, and when we discharge people from hospice services, because we did quite frequently, the desire more often than not from people is to die within their own homes. So on average, about 55% of people want to die in their own home, and we've got documentation such as advanced care planning and preferred place of care, where people can specify where it is that they would like to die, and they can do that well in advance as well. When they've received the diagnosis of a life-limiting condition, they can say that they want to die at home. But what we know and we experience is that planning for somebody to be at home for whatever time period that is quite a big undertaking, because there's lots of processes and systems that we need to kind of activate before that person's discharged, lots of services that we need to get in place. And quite often what we don't know when we're discharging somebody is their kind of status in respect of, we don't ask about finances necessarily. We don't necessarily ask about, you know, have you got loft insulation, or is your home insulated, have you got double glazing? They're not kind of the questions that we ask in the process of discharging as a healthcare professional. So we need to know what people need and get those services into place. And in terms of finances, social care has received bigger cuts to social care income than the actual NHS has. And of course, if somebody's wanting to die within their own home, then we're heavily reliant on what's available from a social care perspective, you know, and involving sometimes social workers, district nurses. We would need to sometimes order specialist equipment, as Jamie referred to, so special mattresses, special beds. So quite often when somebody's being discharged home, there is some disruption in the respect of somebody's bed area may need to be moved down into the living room. So I know Elaine talked about getting the house fit and warm and as it should be can be quite disruptive and take a little time to organise. So can discharging somebody home sometimes, if there's a lot of adaptations that are potentially needed. And what we know is that in 2022 the figures were that 28.7% of people actually died at home, which was an increase of post-COVID times. So it is being enabled, but the for people to be at home at the end of life, it takes a lot of input, which is fine if we can get all that into place, but completely can hear what's being said around people feeling more cold more often, needing to perhaps have the heating on more frequently, like you've said, running medical equipment, but also that a life-limiting diagnosis is not solely ring-fenced for people over the age of 65, for example. So I've looked after people in the 20s right up to people being 100, and all the ages in between. And again, as been alluded to, and we see this, that people are now working a lot longer before they retire, and are paying mortgage payments well into being in the 60s, for example, and if we can get somebody home and for them to be at home, it might mean that the partner has to give up work to provide the care that's not available in the community, because there isn't 24-hour care unless you pay for that privately, and that's extremely expensive. So what you tend to find is that partners and family members will step in to fill the gaps where that care is missing, and that might mean that they then have to either massively reduce their working hours or give up their job altogether. So I know the figures from Elaine showed that if you're single, you're more likely to be in fuel poverty than if you're in a couple or a relationship where there's kind of a double pot of money, so to speak. But that income can soon be depleted if people are having to pay for care within their own home, which is often means tested as well. So that can significantly reduce the pot of money and the resources that people are unable to kind of dip into really at that time. And there's also something to think about in terms of our ageing population. So people are living a lot longer, often with life-limiting diagnoses, and people can receive a diagnosis of a life-limiting condition, but then still live for longer than that year. So it's that assessment of somebody's condition, and everybody's condition progresses differently. People respond to treatments differently. So we've also got, with the ageing population, frailty. So frailty is a cause of death. It's not life-limiting in that sense of a diagnosis of a cancer or a non-malignant diagnosis, but people become frail and require good quality palliative and end-of-life care. So again, it's about how we use descriptors or how we define who would be able to benefit from any kind of tariffs or discounts, and how do we reach those less reachable populations, for example. So I know from a hospice environment, hospices tend to be in situated quite often in quite middle class environment, you know, it's in places where they are and are not always accessed by everybody whose religious belief, for example, may not believe in hospices. So it's quite, it was referred to in literature once as a Rolls-Royce service for the few. So these patients are not just going to be accessing hospices, they're going to be within hospital environments, so healthcare professionals will be looking after those people in those environments as well. It's not just about that hospice environment, but equally, how do we kind of target, for want of a better word, those populations that feel out of our reach, that we know need our care and input. So like, you know, you've already referred to some of those groups that are more likely to be in fuel poverty. And again, it's people's standards of housing and poverty, you know, in general overall for everybody, struggling with the cost of food and the cost of living in general. So, you know, even if you're well and have a good job, I think everybody's feeling that. So I dread to think how people who are placed in a difficult financial position through, you know, no fault of their own and the unfortunateness of a diagnosis might be feeling at a time when there's a lot of pressure on them anyway, regardless of the fact of whether they can think, you know, I'm waiting to put the heating on till 6 o'clock and it's 3 o'clock and I'm freezing cold. So the realities of any policy, like we know, it's got to translate into real life. So you know, I think certainly gathering information from real life people, and Jamie provided that quote there from that lady, which is really heartbreaking to know that somebody you love very much is in a situation like that. So again, it's considering those types of things really, and people's circumstances have changed greatly, like you say. So you know, people working a lot longer now when they're getting older, and I think what we want is for people to have a good death, and be as comfortable as possible with as much dignity as possible, which is what any healthcare professional would want for somebody at the end of life. So hopefully these things will transition and kind of make a difference in the longer term. You're on mute, Graham. I don't think I am.
Back. Thank you, Sarah. It was really useful to hear about your experiences there and your perception of this. It's really valuable. What we're going to do now, if Zoom allows us to, is all go if the panelists could turn on cameras and mics, and what I'd recommend, I don't think I can do this for everyone, but I think if you go to the top right-hand corner of Zoom, you can select hide non-video participants and then view as a gallery, and then you should see the kind of panel on the screen. And what I can see a few questions coming in, which is great. Please keep sending them in. I can read them out, but also if people would like to, if Zoom allows us to, I think if you can raise your hand or something, if you would like to ask a question verbally, then that's okay as well. I think you should be able to unmute yourself to ask questions. Let's see. Jamie's unmuted. Elaine, can you unmute yourself as well? Just to make sure it's working. You can. Good. Great. So yeah, we've got a few questions coming in. Thanks very much to the panelists for really interesting contributions. And yeah, if I could start with a question while there's still some more questions coming in. What really prompted me to think about this is that we often, when we kind of think about end of life care, I think we naturally think about older people. But as you've all alluded to, there's a whole other groups here as well that we don't tend to think about. Are there particular challenges? For example, let's say young adults who may be less likely to be living in secure accommodation, maybe shared accommodation, that kind of experience. What kind of particular things do we need to think about for young adults and other age groups as well? Would anyone like to answer that?
I can offer some thoughts, but I'm sure others will have more to say. I think you're absolutely right, Graham. I think the point about housing and housing security. Obviously, here we're talking about generalities. There are obviously older people in insecure accommodation as well, but that is more common among younger people, and they're also, just partly as a result of that housing, but less likely to have savings built up, probably less likely to have things like life insurance that might pay out, because I think a typical trigger for that is buying a house, right, and covering the mortgage, and those sorts of things. So yeah, I think there are particular sort of financial aspects of younger people with terminal diagnoses that are really important here. Also, not having built up much of a private pension pot, in a similar sort of way that I mentioned in my presentation about not being able to access the state pension. Typically, you can access a private pension early with a terminal diagnosis, generally with less than 12 months to live. But again, if you're younger, you're much less likely to have any sort of substantial savings there. So all of those issues are sort of just compounded, I think, for particularly when you think about the younger end of working age people.
Thank you. Yeah. Sarah or Elaine, would you like to add anything to that before we go to some questions in the chat?
Well, when we looked at the different age breakdowns, we didn't have really sufficient numbers for the younger age group to do any statistical analysis. So, yeah. But I could just sort of imagine what Jamie's saying. It seems, one is more insecure in one's younger years, financially.
Thanks. Yeah. And Sarah, has most of your experience been with older people, or also across the age spectrum?
It tended to be the older generation, I would say. But like I said, I have looked after patients in the 20s, 30s and 40s. And you're quite right. I mean, you know, nobody wants a life-limiting diagnosis. Nobody really plans for it. However, there are a large number of younger people who are receiving a life-limiting diagnosis and are working full time, and like you say, haven't necessarily got any savings, and it just throws them then into a whirlpool of uncertainty. And but equally, that's not to say that if you're at the older end of the generation that you've got lots of money either, you know. So it's about not making presumptions about people's status, I think.
Yeah, could I just add one more thing about that slightly younger age group as well, is that they are also more likely to have children, and as in non-adult children, dependent children, and obviously that adds a layer of cost, but an important and obviously a huge layer of sort of emotional and psychological challenge as well, if you're as a parent of young children diagnosed with a terminal condition. One other thing just to add is that currently, within the way that the support available for childcare in this country works, in fact, this is true across the nation, so I'm mostly thinking about England here, but there are particular provisions for working parents, and those provisions are not extended to people who are not able to work due to health condition or disability, whether or not that's a terminal condition or not, which then, you know, leaves you with a fairly invidious choice of either paying for childcare yourself, which is famously very expensive, or not being able to do that, and then perhaps not getting the break, the respite from parental responsibilities as well, and so having to sort of take on that extra challenge yourself when you're already dealing with so much.
Yeah, that's really challenging. Okay, well, there's a question from Susan Wilkinson. Susan, I'll summarize this, but if you want to mute yourself and expand on it at all, please feel free if Zoom allows you to do that. The question is about asking for proof of basically the burden of proof, really, and is the system working well in terms of how we ask people to prove that they have a terminal illness so that various support mechanisms can kick into place?
Yeah, basically, we get funding through Marie Curie, but through other places at times for white goods. However, for people who are approaching end of life, it's really awful to phone somebody up and say, I hear you're dying, you're needing a cooker, I need a bank statement and your BASRIS form. And the first thing I get asked every time is, what's a BASRIS form? I feel awful. I don't think it's fair on the advisors, but I feel absolutely terrible for people who are exceptionally ill. And it's very difficult to get a bank statement these days if you don't normally use computers, aren't a fait with apps, and even people who do know how to use the apps don't know how to download and send bank statements. They don't know how to go back and get a BASRIS form or even getting a written diagnosis. My mum died of cancer, and they were surprised that she was still alive when they finally sent the letter out 2 months later. And the situation I was in, I kept getting in, I was her carer, I was inundated with phone calls from people wanting to help, where my mum was in a situation where she wasn't in poverty. So I was having to deal with people going, we need you to send us this, 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 and this. And I was going, is this means tested? Yes, it is. Right, we don't qualify. Can you just leave me alone then? So yeah, it's this burden of proof every time these funds do become available. It's very off-putting for us, but it's very, very difficult. And whenever I challenge this, I'm told, oh, well, we're audited, so we have to do it. Not last year, the year before, there was an agreement on the White Goods Fund that if it was a Marie Curie referral, then it would be taken as read that the person qualified, and we didn't have to ask for burden of proof. But in the 24-25 round, back in the late winter, early spring, that disappeared and we were back to demand and proof again. What can be done about this?
Thanks, Susan. Who would like to respond to that?
I think I'm not sure I've got answers, Susan, but I fully agree that that's really important. In a previous life, I was a frontline debt advisor, so I definitely understand the difficulties that people often have in providing those sorts of proof. I know, and obviously that's heightened at a time when someone's dealing with a terminal illness. I think means testing of support when someone has a terminal illness, as I sort of alluded to in my presentation, it is often, I absolutely see where it comes from, but just given the way in which a terminal illness can lead to higher costs and can make people's financial lives very difficult, even if they don't qualify for means tested support, I think that's often, it's trying to draw slightly too fine distinctions than actually works in practice. I think, yeah, I think it's very challenging, and it's not unique to this issue, right? There are issues with means testing and provision of bank statements, and filling out income and expenditure forms or whatever it might be across all sorts of things. I don't have the answer. I think one thing that would help, although I completely realize it doesn't solve the problem, is improving the availability of advice services more generally, so that there are more people who can assist with some of those things as well. And that's a real, for example, in hospices, those that do employ specialist benefits advisors, for example, they're not commissioned for that service through the NHS. That has to be effectively fundraised for. As Sarah mentioned, physical hospices, sort of place-based hospices, do tend to be in middle-class, more affluent areas, which I would imagine, and I'm slightly guessing here, but I would imagine that is partly a function of the reliance on fundraising. Because those are the areas in which you can fundraise more, in which people have more income to offer, to donate. So all of these things are a real challenge, and I think there'll always be need for some sort of certification at some point in the process, and I think trying to find ways to streamline that and make that easier is really important. And I haven't got practical answers at the moment, but I'm very interested in what others think might be good ways to assist with that.
Thank you. Sarah or Elaine, would you like to come in on this one?
I think it's about the terminology that's used as well throughout somebody's experience from diagnosis. So quite often, I taught advanced communication skills for years and worked with consultants, and it's not just consultants, but a range of healthcare professionals. And sometimes people in a health professional role are frightened to say the word cancer, and to actually, talk about death and dying. So we use euphemisms to soften the blow, or we think we're softening the blow, but what we're actually doing is causing confusion. So a patient might come out of a consultation and say, "Oh, I've not slept all week because I thought it was going to be something really bad like cancer, but he just says I've got a tumour." Now, we know not all tumours are cancerous, but some of them are. So it's about, at the very beginning, the definition and the utilising of the right terminology and language. But also, like you say, Jamie, there will be a need for people, if it's means tested or they're wanting to look at income and expenditure, there isn't a way of getting around how we do that. Because, for those who've ever experienced somebody dying, and you even cancelling their gas and electric or the Sky contract and ringing up and saying, my mum's died and my dad's died or whatever, it feels like they want so much proof of this being factually correct, and you kind of get it from their end, but it's the added pressure and burden that it puts on people who are living this real life experience that we're kind of looking in on and kind of aren't there. But I think, terminology from the get-go is really important.
Thank you.
Can I just, sorry,
Yes.
I don't mean to cut back in, but just on the issue of terminology, I think that's a really interesting distinction as well between the SR1 form and the BASRIS form. So for those who don't know, the SR1 form effectively asks the question, I think I'm quoting this pretty much verbatim, would you be surprised if this person died in the next 12 months? obviously that can be that's quite a stark thing to say to somebody. And I've certainly heard of clinicians who, for I think understandable reasons, sort of postpone that discussion, because it is effectively starting a timer. To the patient, in the patient's mind, it starts a timer, right, of 12 months. Whereas the BASRIS test, and again, I'm summarising, there was a huge swathe of chief medical officer guidance on this, but it's effectively, are you in an advanced stage of a condition that is likely to be terminal? And although that's still not an easy thing to tell somebody, it is. It feels to me, and again, the feedback that I've had from people is that it just doesn't feel as difficult a conversation to have. It is of course difficult. There is an inherent difficulty in this, but it is less difficult because generally people understand that they have a serious condition, and that is an easier thing to discuss than saying you're probably not going to be here in a year. So I think that the terminology of those different approaches. So the BASRIS, again, sorry, I appreciate not everyone here will be au fait with the terminology. And BASRIS is the form that's used in Scotland for devolved Scottish benefits. So the adult disability payment, which is replacing PIP, and I think it's called the pensioner disability payment, which is sort of in an earlier stage of rollout, that's replacing attendance allowance. So within that, there is a sort of similar fast track route to those benefits if you have a terminal illness, but what is counted as having a terminal illness differs. It is broader in Scotland than in the rest of the UK.
Thank you. That's really interesting. I'm learning a lot here about different processes and kind of complexities in the system. Moving on to another question. So this is from Jenny Brearley. And she asks about the role of social housing providers, really. What can landlords do? What can social housing providers do?
So I see Elaine's responded in line to that, which I completely agree with. But I was going to add some points. I might summarise what Elaine said as well for the benefit of the recording, which is that retrofitting housing energy efficiency improvements now helps those who are terminally ill in the future. As well as the fact that social housing does tend to be more energy efficient than the private rented sector. I completely agree with that point about energy efficiency. Although I mentioned in my presentation that it's often not the right time to implement those sorts of measures when someone's in the last year of life. We are absolutely not opposed to energy efficiency in general. If we made the housing stock more energy efficient today, that will help people dying in the future. Absolutely accept and agree with that. And there are also quite possibly some ways. I'm not an energy efficiency expert. If there are ways to address energy efficiency that are not disruptive and can be done relatively quickly, absolutely in favour of those as well. I think the main point that I was making there, at least, was that, for example, the upcoming revised fuel policy strategy needs to recognise the limitations of an energy efficiency based approach for people at the end of life. Not that there is no role for that either in the sort of immediate term in some cases, but also obviously that lays a much better foundation as well. In terms of other things that social landlords can do, the main thing that comes to my mind is just to support their residents to access the support that is available. Now, that support may not be sufficient, but nonetheless, getting access to what is there is a helpful start. So that could be support with benefits, that could be support with charity or local authority funds like the household support fund or the discretionary housing payments. But also, I mean, one thing we're seeing in some local areas now is although we think most of the levers for addressing fuel poverty at scale are really with central government, and indeed deaths in poverty, we are seeing some really good examples in local areas of sort of local initiatives. And one I just wanted to mention was that Manchester Council, some of you might have seen this, it's been on the news a bit, have quite recently introduced basically a council tax waiver, effectively, for people with an SR1 form. So it still relies on that form as the gateway. But if anybody in the household, doesn't have to be the bill payer, anyone in the household has that form, then that household will pay no council tax for the up until the end of the financial year in which the person dies. So there is still a little, if someone dies in February, then that's limited sort of run-on support. But if somebody dies in July, then that's a reasonable amount of extra support for that household. And I think that's a really, as far as we know, they're the first council to have done that explicitly, and that's a really good step as well. It's something that we'd like to see other councils taking forward. Now, again, that's not fuel poverty specific, but it takes some pressure off those households. Council taxes are particularly often quite one of the larger household bills. It's also one of the ones that can escalate to enforcement quite quickly and quite dramatically. And so taking that pressure off is really helpful as well. So looking at what schemes are available in the local area as well. There might be other more housing specific or energy specific things social landlords can do as well, but those are things that come to my mind.
Thank you, Jamie. Elaine, is this something that you looked at in your study?
Yeah, if I could just add to that, yeah, we make a good point that yes, fuel poverty is higher in social housing, but it is more energy efficient generally than private rental sector. The issue is that people who are in social housing tend to be in more vulnerable groups. You have a greater preponderance of disability in people who are in social housing. We have a greater proportion of people who are pensioners and on low income in social housing as well. So that's what's coming into play here. It's the issue of affordability rather than the state of the housing. And I think that's sort of important to consider in the fuel poverty consultation. So there is the affordability pillar to fuel poverty as well as just the housing energy efficiency. It's more than one criteria.
Thank you. There's another question here actually for you, Elaine, really. This is from Jen McCallum, just asking for a bit more detail on the geographical scope of the research. She says, was it conducted across the UK as a whole? Does it focus on particular regions, and did you break down findings between different regions?
We covered the UK as a whole, and we did a regional breakdown of that. And we noted that London, the North East and Northern Ireland had higher rates of fuel poverty. And now there could be various reasons for that. It could be that in London that the housing cost is much higher, therefore that's having an impact on what income you have to spend after you've paid for housing. In the Northeast, for instance, tends to be more low income, so that affordability factor comes in. And in Northern Ireland, a lot of the housing stock is perhaps older housing stock, dependent on oil fuels, heating, and so it's more related to the housing stock in that context. So that sort of illustrates the fact that there are several different variables at play when you're talking about fuel poverty.
Okay, thank you. There's a couple of questions about the social tariff idea. So one from Lydia Thompson is really, I think, about the term social tariff and what implications that carries, and if we think that's the kind of the best term to use, I guess. And by the way, feel free to chip in, unmute yourself and expand on this if I'm not summarising it very well, or you've got something to add. And then from Mohammed Ahmad, who just asked to elaborate on the idea of social tariffs and ask for the difference between kind of social tariff and subsidy. How is it just about how we talk about it, or is there something quite different about this approach?
So to me, a social tariff is a subsidy, and there's a where that subsidy ends up falling is a separate question. I think we sorry, I'm just making sure I've also got the got the question in front of me. So I think when talking to policymakers, they understand the concept of a social tariff. Social tariffs exist in telecoms and water already in slightly different ways, but they do exist, and it's something that policymakers talk about, and that's who our report is aimed at, and so that's why we've used that terminology. In terms of how people themselves understand the term and whether they understand the term, that's a very good question. I think to me that's sort of a second order question, because I think first we need to get some sort of level of support in place. Now, I personally don't mind what you call it, but I think when talking to yeah, civil servants, policymakers, politicians, they understand this concept. It means something to them. I think if we do manage to get an agreement to introduce something like this, then what it is called will matter to get awareness among the public. Right. It may well be that social tariff is not the right term for that. It could be, help with bills, support with bills. I don't, you could come up with all sorts of ideas and you'd want to test them with people. In the water sector, it's there's water sure and water help, which I don't mean much to me, but I'm not sure those are quite the right ways to frame it either. But I think there just probably is a distinction between how we would talk about it now when we're trying to win the argument to get it introduced, and how it would then be presented to the public. And on Mohammed's point, I think I use them pretty interchangeably. Again, at the moment, our focus is on trying to get the political and policy agreement that some sort of support for bills, some quite substantial support for energy bills, needs to be introduced. I don't have a particular view. I possibly have preferences, but not Marie Curie doesn't have an organisational view about whether that is called a subsidy, whether that is called a social tariff, exactly how that's structured. There are lots of different ways and technical ways to structure these things, and that people like the End Fuel Poverty Coalition have done quite a lot of detailed work on. At the moment, for us, it's just about, at the moment, we just haven't cleared the first hurdle, which is getting that agreement that, yes, we need to introduce something. And once we've done that, then to me, that's the time to tackle, or at least for Marie Curie, as not a specialist energy organisation, that's when we'll sort of start tackling those sorts of things.
Sure, thank you. And Elaine, this was a large part of the study, wasn't it? What's your view on the kind of potential of a social tariff?
Well, I think with social tariffs, as Jamie was saying, we already have something in place in water, as seen as it, an essential basic service, and we should be looking at energy in very much the same way, that these are people with the very human side of them struggling if we don't give this help and get this help in place first, and then worry about how we're going to market it.
Thank you. So I was just trying to read the questions as they were coming in then as well. There's a follow-up on the social tariff issue from Jen McCallum here. I guess, any thoughts on how it practically works? I don't know if there's anything else you want to add on that, if you feel you've kind of covered that.
So what we suggested, what Marie Curie sort of discussed with Elaine around modelling was that was a 50% discount on energy, on an energy bill, and that, I think we took that in part because it was an idea that was an amount of reduction that was A, quite significant, but B, already sort of in the air. There were other organisations. I think we possibly stole it from Age UK as an idea. So it was already sort of in the discussion. Obviously other amounts are available. In terms of how that would be implemented in practice, I think that is an interesting question. I think what would be important from my point of view is that it applies sort of in real time, that it's not something that you sort of claim as a rebate or something afterwards, partly because obviously for prepayment meters that just doesn't work for people, but also even people on credit meters, there may be a cash flow problem, there may be a fear problem of not being willing to do this. I mean, I imagine that there's quite a bit we can learn from the water sector on this, and I think it would be, and I don't actually know the answer to this, but it would be an interesting thing to look at how their social tariffs work with the greater rollout of water meters. And because obviously when you're just doing it on a rateable value, you know what the annual bill is, regardless of the amount of water used. So you can just lop that in half or take 30% off, or whatever the discount you're providing is. That's quite easy to do. And you can do that on an annual basis. When it comes to water meters, I don't know how they do it. And I think that would be something useful to learn from. It doesn't mean they necessarily get it right. But I think that probably would be the place to start. Because, as I say, many more households, including mine, have water meters introduced now, and that's relatively comparable to gas or electric meter. And so working out how that applies there. But I think the principle is that wherever possible, no, it needs to be in some way in real time. I mean, I suppose your build, say your build monthly, you could take it off at the point of billing, I suppose.
Yeah, thank you. I think it's an important issue, this idea of stuff happening in arrears, which is really unhelpful, isn't it? If you're having to pay up front for stuff and get it back a little later on, this is really unhelpful. We're getting towards the end, but thanks. It's been a really interesting discussion. There's one remaining point that we haven't really picked up on, which in the questions, which is prepayment meters. So I'd like to just address that briefly, and maybe what we'll do is go around each of you, and just if you could use it as a chance just to sum up if there's anything else you want to kind of add in closing. So maybe if we start with you, Elaine, if that's okay. Were prepayment meters in your research?
Yes, we did look at the fact there was an increased risk of fuel poverty for those on prepayment meters, and that is in the report. It was when we came to sort of apply a social tariff and look at how many people were still in fuel poverty and extreme fuel poverty. After that, we got down to quite granular, small sample sizes then. So we couldn't really model the social tariffs on that and the impact. So the issue with prepayment meters is you can no longer, I think it was since 2023, I'm going to say, that you can no longer force fit a prepayment meter to someone who's terminally ill. But there will be people there who've already had a prepayment meter fitted earlier in life, and that's still present when they become terminally ill. So if we could do something to switch them to ensure they're not forced to go out of the house to top up their energy meter, as someone was saying in the discussion. I believe there are some suppliers now where you can top up your meter online, which would be helpful. I also believe that we currently we know the unit rates now for people who are on prepayment meters are comparable to those who are on credit meters. So there have been some improvements in recent years. But it is certainly something that, we need to keep on top of. Yeah, and it's an important point we were saying about people having to have the expenditure and then claim it back afterwards. That doesn't really help. You really need that help in real time, coming straight off the tariffs on your bill, so that you're not stressing about leaving a debt for your partner and things like that. Which is one of the discussions when we were doing the project. We had a representative from someone who had experience in real life of this situation, who was saying that her husband had fretted about leaving her with big bills to pay. So it's a big hurdle to overcome that.
Yeah, thank you. For that response. Jamie, would you like to add anything on the prepayment meters? I don't know if this is something you've been looking at as well.
I endorse everything Elaine said on prepayment meters. One final point I'd like to make is actually around the social tariff and the limits of our design work on it, which is actually we haven't. One area that we know needs further exploring if we get this agreement is actually how it will apply to people using non-mains fuels, so particularly heating oil or other alternative fuels. I think that's a tricky one to crack, but I think it's something that we just need to keep in mind when we're thinking about this, to make sure that those households, particularly in rural areas, particularly in Northern Ireland and some parts of Scotland, aren't inadvertently left out of any such solution.
Yeah, that's really important. Yeah, thanks. And Sarah, you've got pretty much the last word.
Well, my mum always said that I had to have the last word when I was a child, so it's probably apt. But just thinking about my experience of working very closely with patients and families, often they're not aware of what is available to them, because if they've never needed to access anything like this before, they don't know where to go to start with. And sometimes there's an element of pride. So if somebody's worked really hard and has never maybe accessed any kind of benefits or support before, I have seen people who've been quite reluctant to accept any help. So it's about us being able to have that information to hand to work with that individual and say, you are entitled to this is fine, there's no judgment of anything, this is to help you. you know, to be as comfortable as you can possibly be in the last year or so of life. You know, so it's that, again, going back to terminology, but also about making people more aware of what they're able to access, and supporting those people who might feel a bit too proud to ask for help.
Great, thank you, Sarah. Well, thanks to the three of you for really insightful discussion there. It's really interesting. Not something I've given a lot of thought to in the past. So, and I hope as others that we've all learned something about this challenging problem. Which obviously there's a lot here that's very familiar in terms of fuel poverty and housing and healthcare. But this is very specific challenges and a very specific group of people with particular challenges that needs a really sensitive treatment. So I look forward to hearing more from the research as well. You said November, I think. I think we're holding you to that now. So maybe on the FPRN mailing list we can announce when that research is ready. And yeah, well, I think we'll close it there then. I'm just going to put in the chat. I'll just put some links to FPRN so you can see what other things we've got coming up. And we'll send you out an email once we have the recording, and we'll have the slides and links in that as well. So thanks very much, everyone, and have a good afternoon.
Thanks, Graham.
Thank
Thank you, everyone.
Thank you. Bye-bye.
Bye.